Hello, I'm Yasamin Ashanable from Qatar University. I'm a fourth-year medical student, and I'm the presenting author for the poster of our study, Prevalence of Asymptomatic Hyperuricemia and its association with prediabetes, dyslipidemia, and subclinical inflammation markers among young healthy adults in Qatar. Hyperuricemia is the elevation of serum uric acid levels above 6.8 milligrams per deciliters and above 7 milligrams per deciliters. It causes the formation of monosodium urate crystals, which can lead to diseases such as gout or nephrolithiasis. Asymptomatic hyperuricemia, on the other hand, is the elevation of serum uric acid levels above 6 milligrams per deciliters with subclinical metabolic disturbances without the presence of crystal-forming diseases. Asymptomatic hyperuricemia is a highly prevalent phenomenon affecting 10 to 20% of the global population, yet there are no guidelines for its treatment. Recent studies have demonstrated the link between incidence of chronic metabolic disorders and asymptomatic hyperuricemia. However, its relationship with preclinical chronic inflammatory processes has not yet been explored. The aim of our study was to investigate the prevalence of asymptomatic hyperuricemia in Qatar, as well as to examine its relationship with changes in markers of hematological indices, dyslipidemia, prediabetes, and subclinical inflammation. Our study design was a cross-sectional study design, and our cohort consisted of young adult Qataris who were aged between 18 and 40 who were devoid of any comorbidities. We had 871 subjects, and data was collected from Qatar Biobank. We defined hyperuricemia as serum uric acid levels that were above 6 milligrams per deciliter, and we divided our outcome variables into four distinct groups of outcome variables. The first category was hematological indices, which included hemoglobin, RBCs, folate, TIBC, and white blood cell count, as well as monocyte percentage. Next, we had lipid panel, which included triglycerides, HDL, and LDL. Glycemic markers were C-peptide, glucose, HbA1c, and subclinical inflammation markers were ferritin and monocyte to HDL ratio. The means of outcome variables were compared using t-test and menu test to produce their p-values. To assess the association between the outcome variables and serum uric acid levels, we used correlation tests, mainly Pearson's correlation and Spearman's rank correlation tests. Next, we identified potential confounders in our study, which were age, sex, BMI, smoking, and exercise. And lastly, we produced two multiple linear regression models to predict the difference of means for each outcome variable between hyperuricemic and non-uricemic groups. The first model adjusted for age and sex, and the second model adjusted for age, sex, BMI, exercise, and smoking. The results of our study showed that the prevalence of asymptomatic hyperuricemia was 21.2% in our Qatari cohort, which was slightly higher than the global prevalence. It was a statistically significant difference in means for all outcome variables except white blood cells when compared in hyperuricemic and non-uricemic groups. And our correlation test showed a statistically significant association between subclinical inflammation markers and elevated serum uric acid levels, as demonstrated in the scatter plots here. It also found an inverse relationship between HDL levels and serum uric acid levels. When it came to our multiple linear regression models, after controlling for confounders, there was no statistically significant difference in means for hematological indices. Multiple linear regression models also showed that there was a statistically significant decrease in HDL levels with increase in serum uric acid levels. This statistically significant relationship was held to be true even after adjusting for confounders such as BMI, smoking, and exercise on top of age and sex in the second model of our multiple linear regression. Multiple linear regression also showed a positive relationship or an increase in the mean C-peptide and MHR levels when compared in hyperuricemic and non-uricemic groups with elevated serum uric acid levels. This was statistically significantly true in both of the models in our multiple linear regression. The other outcome variables were statistically significantly associated with elevated serum uric acid levels in the first model. However, when adjusting for further confounders such as BMI, smoking, and exercise, the statistical significant association was lost. To conclude, the prevalence of asymptomatic hyperuricemia was found to be 21.2% in our Qatari population. Asymptomatic hyperuricemia is associated with markers of dyslipidemia, prediabetes, and subclinical inflammation, and our study would like to advocate for subjects with asymptomatic hyperuricemia to be informed about the potential risk of development of chronic diseases, and we would also like to recommend suitable lifestyle modifications to prevent the incidence of such disorders. We'd also like to thank Qatar Biobank for providing the cohort data for our study, and also Dr. Suhail and Dr. George and Dr. Tawanda from the Department of Population Medicine at College of Medicine, Qatar University for their help with the statistical analysis.